I think that's what happened with the PA catheter.
Baby steps, though. They can take some baby steps along the way, just to show them that we're affecting output when we crank stuff beyond here, or you're affecting that we can bring people to the table and maybe get some good quantity.
It would be great, though. I love that stuff. Okay.
So,
Just every time I move it, sorry, but just leave it. It should come. Okay. Okay. Cheers. Nice to see everybody. I see some familiar faces in the crowd. I'll see you guys at work tomorrow. And my wife's here actually to support me, or she has no idea what I do at work. So I'm going to tell her a little bit what interstitial lung disease is and why I have to answer calls all the time about these patients that are really, like Dr. Dawood had mentioned, are very challenging, and they're particularly challenging in the outpatient setting as well as the inpatient setting. You know, there's not a lot of evidence guiding what we do in the care of these patients, but I can touch base and share some insight in regards to what I do for these patients that I spend most, not all, of my outpatient setting and time caring for these folks. Breathe easy, confident IOD in the ICU with confident care. You know what I did? I was like, I last gave a talk on interstitial lung disease of like the family medicine department, and I gave another one to another association. I was like, I'll put this into ChatGPT. I was like, I need a better title. Come up with something else. So I put this into this topic into the ChatGPT, and this is the title it gave me. I like it. I have no conflicts of interest for this. I'll just briefly share some of the objectives of this talk, is just kind of provide some overall context on how interstitial lung diseases are organized. It's the most confusing part about all of it, and that's why it's largely challenging to take care of these patients. Discuss key components of the IOD evaluation. I'll keep us on time, so I won't spend too much of this presentation on that, because a lot of that takes place in the ambulatory setting, or it should. And essentials of disease management in the ICU. So why it is so confusing? Because interstitial lung disease, diffuse parenchymal lung disease, and pulmonary fibrosis show up in patients' charts, and we're trying to figure out what's going on with them. How do they all mean the same thing, or are they different? How do the physicians and the respiratory therapists and the nurses see this disease in the chart? Is it all part of the same process? To be honest with you, it's just an umbrella. Interstitial lung disease is just an umbrella term. So it's a term that reflects over 200 different types of lung diseases. So that's not incredibly helpful. So when we see and care for patients with the diagnosis of interstitial lung disease, that is incredibly unhelpful. So a large part of what takes place in the clinic, I try to figure out exactly what they have. So interstitial lung disease, like I shared, is an umbrella term that reflects all these different categories. The most common one I see in clinic, at least, is idiopathic pulmonary fibrosis. When we see them in an intensive care unit, they'll fall into the inflammatory bucket, which is the hypersensitivity pneumonitis, the autoimmune interstitial lung diseases, and so forth. So this is just one way to kind of categorize it. And I spend about 15 minutes in clinic going over with patients exactly what this all means in terms of their workup, which is pretty comprehensive in that setting. So interstitial lung diseases, they fall, whatever the type of lung disease they have, it falls into the spectrum of disease. Either it's predominantly fibrosis or predominantly inflammatory. My hope is that when we see patients in the intensive care unit or in clinic, that they're on the inflammatory end, because treatment options for them are a lot larger in terms of spectrum of things that we can offer them. For patients with predominantly pulmonary fibrosis, though, to date, we don't have a cure for pulmonary fibrosis. We have some therapies that can slow down the decline in lung function, but nothing that can stop it or reverse it. So we have to be aggressive on the inflammatory end of things so that they don't progress to the fibrotic part, which is essentially lung scarring. So I'll keep this brief because most of us work in the inpatient setting, but in the clinic, this is sort of what we do. It's pretty intensive. So I spend if I could, if my hospital let me spend like an hour with them, I would spend an entire hour, but I try to put it all into a 30-minute visit. But it's a pretty comprehensive history taking that takes place early on, followed by some lab tests, EFTs, of course, plus minus bronchoscopy. We have surgical lung biopsy and cryobiopsy options for us now if you think that would help us with the differential. And establishing a diagnosis. And then I'll talk a little bit about the MDD is a multidisciplinary discussion. So that's where, the pulmonologist, the thoracic radiologist, the pulmonary pathologist, the thoracic surgeon, all of us get together in a room to discuss things and kind of see if we can come to a consensus diagnosis for these patients. And there's treatment, disease monitoring. So it's a huge, long, extensive process. This is sort of what it looks like. This is a picture of what my fellowship looked like. Generally, it'd be a lot of faculty sitting around the table. The fellow would present, and the fellow would get hammered for about 10 minutes about why we came up with the decision we're making that we did to get to this place. But in any sense, it's a big, long, comprehensive thing, and a lot of thoughtful folks are sitting in a room putting their heads together to kind of come up with the correct diagnosis, or at least a leading diagnosis for these patients that show up in our clinic without one. But that's why it's challenging to care for these patients in intensive care unit. It's particularly for those that don't have a diagnosis. We have to work a little bit retrospectively and prospectively all at the same time. And we have to do so in a lot more expedient manner. So I'll just kind of walk us through some of these important questions that you may have in the audience about caring for these patients in intensive care unit with pretty hypoxemic respiratory disease. So I'll share a case. There's a 32-year-old woman, never smoker, history of scleroderma. It's an autoimmune connective tissue disease that I often see in clinic. That systemic that disease doesn't spare the lungs. If the patient has that diagnosis, generally they'll have some sort of lung disease associated with it. There are oftentimes a microventilated mofetil or CellCept, and they show up to your emergency department with shortness of breath. Their oxygen saturation is 75% on room air, so they're initially placed on 10 liters of oxygen. And then the ICU team is going to be consulted, of course. That's a lot of oxygen. Their respiratory distress, their PO2 is pretty low, and they get placed on 100%. Sorry, man. FiO2, high flow nasal cannula. That's how everybody documents it. But I get what you mean, though. And then that's a lot of oxygen, and the patient is breathing really fast. I think this was maybe brought up in a previous talk. That ROX index, or that suspicion that the patient is going to need invasive support, goes up, and the patient gets intubated and transferred to the unit. So I'll briefly touch base on some of these questions, and I think these are things that I ask myself when I care for these patients in the intensive care unit all the time. Because it's, these patients are challenging. History matters for these patients, and their differential for why they're so hypoxemic is still pretty big. Why are they so hypoxemic? Why is their lung compliance suck? How do we manage these patients on the ventilator with such terrible gas exchange and such terrible respiratory mechanics because of their diffuse parenchymal lung disease? Should we biopsy these patients? Should we activate ECMO team for these folks? And what's the prognosis for these patients with severe hypoxemia and oftentimes hypercapnia as well? So a little bit about the history and why it matters so much. These patients show up in the emergency department and they got lungs that look like this. These are terrible looking lungs, by the way. But those big air spaces at the bottom of the lungs, that's bronchiectasis because of lung fibrosis. So it's either the tissue around it is fibrotic and pulling it open. That's why it's called traction bronchiectasis. But it's probably some airway injury as well, and that's why it gets dilated. And there's a lot of ground glass here, some foundations at the bases of the lungs. You know, this kind of looks like this patient for sure has pulmonary fibrosis and definitely has interstitial lung disease. I don't know what type, but there's also an acute component on top of this. So these patients, you know, when I see these patients, whether or not they have a diagnosis, it does help to look into their comorbidities. Are they immunocompromised? So say this patient has connective tissue disease, autoimmune disease, and that explains their pulmonary fibrosis on the CT scan. Maybe this is all infection. Any new medications? Their shortness of breath, how did it progress? Any change in their cough? The reason why I ask that is because patients with an acute flare of the interstitial lung disease, their shortness of breath and cough develops over a week. So like they'll be like, oh, 2 weeks ago, I usually go to the gym, but I was having this like dry cough. I was like, my family is sick. And then I was a little bit short of breath, but that was so big a deal. I could still get through my workout. But then 1 week ago, I was going out to my mailbox and I was just a little bit short of breath. I thought that was weird. You know, I went to urgent care. They gave me antibiotics and sent me home. And then, you know, yesterday, though, my shortness of breath was pretty bad. I couldn't even walk to the refrigerator to get myself a drink. And this cough is really nagging me. So, you know, it's nagging me so bad. My family told me to go to the emergency department, and here I am. That's the kind of story for interstitial lung disease or flare of their disease. Infectious pneumonia doesn't wait that long. You feel terrible pretty quick. It's pretty acute and you look pretty terrible. The appetite goes down, things like that. So that's why the history helps for these particular patients where they show up in an emergency department and in our intensive care unit. So acute respiratory deterioration, that's part of it. So this is not to make this algorithmic because, you know, as was shared previously, we shouldn't treat these patients as an algorithm. We should treat them individually. But in any case, I think the reason why I put this slide up was really for the arrows. You know, if this is an interstitial lung disease exacerbation or a flare of their disease process, it's probably due maybe an infection, aspiration, drug toxicity, active volcano on the Big Island, or a recent surgery procedure, things like that. But most common, I don't know if there's a most common, but one common reason for an interstitial lung disease flare or an acute process is actually infection associated. You folks have maybe gone over this in the previous sessions and topics of this, so I won't spend too much time. But the reason why they're so darn hypoxemic is because they've got like a lot of inflammation in their alveoli. So there's going to be, it's kind of similar to air, I guess, to some degree. There's fluid in their alveoli. And for these patients with chronic lung disease, there's fibrosis in the interstitium. The interstitium is the lining between the alveoli and the blood and the capillary. It's usually very thin, and it's super easy to exchange oxygen and carbon dioxide for these patients, particularly challenging. You know, so the acute inflammation plus the fibrosis, super hypoxemic. This is already discussed, but I love high flow nasal cannula. It's amazing because you know, be able to deliver that type of flow to match their inspiratory effort with humidified air is incredibly helpful, because these patients oftentimes just need time to get through their acute process. And if we can save them from being on the ventilator, particularly patients that are already on immunosuppressive therapies, putting the endotracheal tube in does increase their infectious risk. So if we can support them through a high flow nasal cannula, that'd be awesome. It washes out the carbon dioxide from their dead space. It doesn't fix the entire problem, because a lot of times they have physiologic dead space. That's also an issue, and there's a reason why they're got some acidosis associated with their disease process. But it really does help, and it helps with their work of breathing as long as the flow is high enough. And it's definitely probably more comfortable than the breathing tube. Just gonna guess. Sorry about Deadpool, but like, I mean, anybody knows me, this is like my favorite movie, my favorite character. But anyways, so say if the patient shows up on the ventilator, their PEEP is 8, their respiratory is 14, we dial that in. Their FiO2 is 80%, their PO2 sucks at 65, and they're on 7 ml per kilogram ideal body weight. But their plateau pressure, if you said the patient on volume AC, so we can check their plateau pressure is 50. Have anyone seen a plateau pressure of 50? Yeah, that wasn't pneumothorax. But in any case, you know, that plateau pressure of 50 is pretty darn, that's a lot of pressure to deliver whatever tidal volume that we had set, which was 7 ml per kilogram. It's a reflection of how really non-compliant their lungs are. And their lungs are non-compliant, and it's a kind of overlap a little bit with ARDS. There's a loss of surfactants. Surfactants necessary to decrease surface tension and lining of the alveoli, and it's a large reason why it keeps the lungs, the alveoli from becoming atelectatic. But there's ulcerations to the lung extracellular matrix for patients with interstitial lung disease. And for the now, I love pulmonary function tests, partially because I'm a pulmonologist, not partially, because I am a pulmonologist. And, if I were to, I'll speak as loud as I can so I can show you guys why it's so hard to breathe. So you see the tidal volume here, it's the small waves here. Those small waves of we're breathing right now, sitting down we're sitting down in your chair. That's our tidal volume. But you see our total lung capacity there, and we see our vital capacity. Those all fall when patients have pulmonary fibrosis. So as the vital capacity starts to shrink, it starts to look a lot like our tidal volumes. So that means at some point, when the lung compliance goes gets really terrible, it's hard to breathe with any sort of exertion because at best they can only breathe like how we're breathing right now in our seats. That's our tidal volume. And their vital capacity starts to get closer to their tidal volume. That's why it's so darn hard to breathe, because they want more oxygen. They want more air, but they just can't get it because their lungs compliance is not so good. So in short, because I'm also an intensivist, so I love physiology. So, the reason why it's so hard to breathe is the loss of lung compliance, plus the hypoxemia that I discussed previously, plus the desk-based ventilation. The PaCO2 goes up, they're going to want to breathe faster, and then boom, intubation. Not briefly, maybe I'll discuss some ventilator strategies. And there's some, I suppose they're best practices, but there's not a lot of evidence driving what we do in caring for these patients. Or to be honest, but ARDS has, even they have better, the ARDS has better guidance than interstitial lung disease. We're like working, not necessarily, we can work thoughtfully. And this is kind of how I see patients, and based on how I see them in clinic. And if I had to take care of them in the hospital, this is what I do. This is already discussed previously, but gosh, if the ventilator could do the math for me, not that I can't do a little bit of subtraction, but sometimes when I'm really lazy, if the ventilator could give me driving pressure, I could just be mindful to check it pretty frequently, because that's how I titrate their PEEP. So each patient I care for, I titrate their PEEP individually. So I have to spend time at bedside kind of looking at their plateau pressure, and I compare it with their PEEP, and I calculate their driving pressure, and I dial in the PEEP for that particular patient. So that's generally how I set it for all patients. Low tidal volume ventilation, it's not, interstitial lung disease flare is not ARDS, so we don't have to do low tidal volume ventilation for these particular patients. Although, there's some data suggesting that, you could use low tidal volume ventilation for every patient. I kind of get that. I don't dislike that idea, but in any case, they're not ARDS. So sometimes they ask us, should we prone patients? Like, well, maybe it'll help, but I don't have evidence driving that decision making. FiO2 and invasive respiratory support is tolerated. We'll wean it as fast as we can. And some of these patients may benefit from neuromuscular blockade, but really as if their ventilator dysynchronous is causing some hypoxemia. Not every patient needs to be on neuromuscular blockade. And generally, once we get to this point, we're starting to think of these patients needing perhaps high-dose steroids or neuromuscular blockade to get them through their severe hypoxemia. Speaking of early trach, these patients might be good candidates for early tracheostomy. You know, with a reversible disease process that would require a lot of support and immune suppressive therapies for a long period of time, these are the kind of patients that we get set up for, or I would at least start considering that pathway for that particular patient. I diurese everybody. Lung biopsies. So, you know, like I share with you, some of these patients, they come to our emergency department, admitted to our ICU and our hospital systems without any diagnosis. But, you know, should we get lung biopsy? Is that going to change management? The truth is, high resolution CT scanning has changed the game in terms of our understanding of what is the underlying disease process for these patients. If they have a typical disease pattern radiographically, they'll have, say it's usual interstitial pneumonia, in the right patient, say they're a man in their 70s that smokes cigarettes, it's most likely idiopathic pulmonary fibrosis. That's the reason for that particular disease. They do not need surgical lung biopsy, which is not without its own set of complications. It's a pretty high risk procedure for even for our ambulatory patients. For patients in the intensive care unit, I don't think we're going to be smart by getting these patients, putting these patients through this particular procedure. Partially, what ends up happening, it's not like lung cancer. We biopsy them and they get a diagnosis of adenocarcinoma, squamous cell carcinoma. What we do is we get a pattern. And then we got to take that pattern with their disease history, with their pulmonary function test, with their CT scan, and we got to talk about it as a team. That's how we come up with the decision with the diagnosis for these patients. So in that setting, you know, with a hospital mortality of 54%, how bad do we really need to know? Probably not so much for most patients. None of this is, I can't say no patient in the intensive care unit ever deserves at least a thought of whether or not they need lung biopsy. But most patients don't. What are the pharmacologic options that are available to treat acute exacerbation? Well, super high dose steroids. So hopefully they're on that inflammatory part of the spectrum and they're going to respond to treatment. Generally, like 0.5 to 1 milligram per kilogram ideal body weight is generally enough. That's not a small dose. 1 milligram per kilogram is a big dose of steroids for these patients. But sometimes for patients that reach the unit, they need the biggest dose. So they need the pulse dose steroids. And say if I had a diagnosis of an autoimmune disease, I usually will work with a rheumatologist to discuss maybe or not they need bigger therapy than just pulse dose steroids or pulse dose steroids alongside rituximab. Generally, those patients are those that are coughing up blood. The alveolar hemorrhage patients, they're pretty severe, and those patients get more than just pulse dose steroids. They get that plus Rituxan, plus minus plasmapheresis. But those are other options for these patients with interstitial lung disease flares that are so severe they find themselves in the intensive care unit. ECMO candidacy. This is maybe it's not so tough a question, but generally, I think the first thing I would ask myself before entertaining calling the ECMO consult would be, are they candidates for lung transplant? Because if they're not lung transplant candidacy, ECMO really is bridge therapy, so they're generally wouldn't be considered candidates for ECMO. But say it's just, that patient in that scenario I just brought up, a young lady with an autoimmune disease that's so severe that landed in intensive care unit. I think they're going to be ECMO candidates. But generally, how I would think this through is whether or not there are lung transplant candidates would be a good start. And of course, discussing it with your multidisciplinary teams. So, this is just this data was collected I think one of the articles I previously presented this is the data from it in terms of short and long-term mortality is high. You know, as I described, these patients already come into the hospital with lots of reasons for severe gas exchange abnormalities, but, you know, 6-month mortality, 96% for patients with interstitial lung disease on mechanical ventilation. I really think this is more so to inform the goals of care conversations that we have with patients. This doesn't mean that there's nothing that we can do for these patients, right? There are going to be patients that are going to respond to therapy if we just give them time. These are the patients that early tracheostomy actually makes sense, just to see if we can get them through the acute process and see where that takes them. I turned in this PowerPoint and I was like, I don't know why I put this particular picture up, but sorry about that. More important thing is the stuff on the inside. This patient with scleroderma, acute flare, received postal steroids, successfully extubated, discharged from prednisone, 1 mg per kg, IV by every 30 days. They're mycophenolate. Mycophenolate is a really wonderful drug for scleroderma-associated interstitial lung disease, particularly and pneumocystis prophylaxis. And her disease was severe enough to warrant ICU level care. Early referral to a center of excellence that does lung transplant would be best for this patient. So just in summary, the key points. Leave this the rest of the presentation open for any questions. But just most cases of undiagnosed interstitial lung disease and hypoxemic respiratory failure are responsive to aggressive pharmacologic therapy. Well, I'm not sure about that. But you know, aggressive up front is I think the main take-home point. Defend the PaO2 until medications begin to work. So it does take some time. So like, for example, I was on pulmonary consult yesterday and the patient's like on 15 liters non-breather mass and intimately flush and then taper down to 6 liters. I'm like, where is this patient? But anyways, this patient's on postal steroids. And I was talking to a hospitalist yesterday. Yeah, they might be on high flow Canada tomorrow. They're not right now. But we did decide to just be aggressive with and just give it a little bit of time. I can't say where this is going to go for the patient. Just got to give it a little bit more time. And the patient's not going to be off oxygen in a couple of days. It's going to take a lot more time to get there. Consider high flow Canada use for as long as possible. If you have a thoracic radiologist at your healthcare system that you can go over the imaging with, I would recommend going over the imaging with them. Dry lungs or happy lungs, I don't know. It's always the case. And if they're candidates for lung transplant, they're candidates for ECMO. So I would consider at least reviewing the case with the center that does ECMO for these patients that are pretty hypoxemic. And it doesn't hurt to do so earlier than later. Now, there's over 200 different types of lung disease, but this is by far the worst interstitial lung disease. And this autoimmune lung disease, MDA5 dermatomyositis, is the worst. These patients go from 0 to 100 really fast. They're not like all the other ones that, like I shared, they're like, oh, about a week ago, I didn't feel so bad. They're like, holy smokes. They got severe compliance issues, really bad inflammatory process, and oftentimes is refractory to a lot of the heavy dose immunosuppressive therapies that we have in our arsenal. So these patients are candidates for ECMO. Probably going ECMO pretty early. Thanks so much for a chance to share this talk. I do love, for whatever reason, in taking care of patients with interstitial lung disease. They're really hard and complex as an outpatient, and they're particularly much more challenging in the inpatient setting. But you know, as I shared, on the ambulatory side is multidisciplinary, and on the inpatient critical care side, it's the same. So, you know, work super closely with my respiratory therapists and nursing colleagues and caring for these patients and all the other subspecialty providers that we have available to help. Folks have any questions?
Any questions?
Thanks so much.
Oh, okay. We have a question. Someone in the chat asked, are ILD patients typically responders?
Good question. And the truth is, I'm not sure if there's like a typical or atypical. So honestly, like when they get intubated, if they get intubated, they're paralyzed. So I can get the plateau pressure. So what I'll do is I'll calculate the driving pressure and I'll titrate their PEEP accordingly. So I'll try to find the right PEEP for that particular patient and go from there. Some are, but some aren't. Some, I would imagine some that are more PEEP response for folks that have other reasons to have atelectasis, like obese patients. So obese patients, I would probably be in favor of a higher PEEP to start with, and then also still calculate the driving pressure. But I'm not sure that answered, but yeah.
Thank you for that talk, and actually thank you for taking care of these patients. It's very difficult, I can imagine. In terms of caring for them at home, what are your maybe 2 or 3 challenges in discharging patients like this, and where should we think of in the future that needs improvement to help physicians like yourself care for them?
That's a great question. And the thing about what the biggest challenge, honestly, is Google. So on the first visit or before, I was like, just don't Google anything unless you want to feel bad. Just wait, because for me to like give them an idea of what's going on, I have to just get a diagnosis first. So I tell them like it takes 3 to 6 months for me to do my workup and to give them a diagnosis, because I don't want to label them as idiopathic pulmonary fibrosis, which is pretty grim diagnosis, unless I feel very confident that that's indeed what they have. And I think along those lines, it's a pretty hard thing to go over what interstitial lung disease is. Why do I feel so shortness of breath? Why do I have this cough that just won't quit? And everybody in my family is worried I have COVID every time I come over. A lot of it's just patient education. So I spend most of my time in clinic actually going over why they cough or why they feel so short of breath. Please wear your oxygen, stuff like that.